Hi, this is Dr. Srafil from Ethiopia, University of Gondar, oral and maxillofacial surgery resident. Here, today we're gonna see some topics regarding the specific surgical concerns while treating cleft, palate, and lip patients. As an oral and maxillofacial surgeon, we're going to see some specific and very crucial points to bear in the mind. So as we can see here, we are going to see some specific concerns of cleft lip and palate patient management as a surgeon and as a specific interdepartmental integrity of this developmental anomaly with otolaryngology anesthetic concern, because the intubation and overall operative theater is not going to be as conducive as a routine patient. So the first one that we should be focused, we should be concerned about is the sealing defect, which means just obviously the primary objective of this cleft lip and palate management is sealing the defect. The cleft side of the crack has to be sealed so that the patient's speech and the patient's feeding will be improved. So the second concern will be speech improvement. The third one will be feeding capability. The fourth one will be, we should be focused that those patients, because almost 30 to 40% of the patients are having this syndromic potential. So associated anomalies has to be screened out, like cardiovascular anomalies, cerebrovascular anomalies, musculoskeletal anomalies. Till the recent studies, it is just studied like 24% of these cleft lip and palate patients does have 24% of cardiovascular anomalies and 33 or 35% of musculoskeletal system anomaly. And this especially whether the cleft is isolated cleft lip or combined cleft lip and palate or isolated palate. So in case of isolated palate, we should suspect the patient might have familial tendency, especially paternal tendency, paternal genetic inheritance. So we need to rule out whether the patient does have isolated cleft lip and palate or syndromic. So for that matter, associated anomalies has to be screened. And the fifth one, those patients, because of the opening and the exposure of the eustachian tube, which is running from the middle ear cavity anteriorly into the oropharynx, is in a close proximity and in a close communication, whatever is happening in the mouth, like feeding, during the feeding time, the foreign bodies. So the food is a foreign body for the eustachian tube. So the patient will be suffered from chronic otitis media with effusion. Most of the patients just came with chronic otitis media, suppurative chronic otitis media, and chronic otitis media with effusion, which necessitates us to do repetitive laryngotomy or tympanostomy in order to improve that. And hearing impairment might be there, even conductive hearing loss, and subsequently this conductive hearing loss might progress to become sensory neural hearing loss. So the other thing will be chronic otitis media with effusion. And the sixth thing is those patients will have high probability of upper respiratory tract infection and aspiration pneumonia, because when they feed while the defect or the cleft lip is not repaired, there is high probability of insufflation of the abdomen with air. So that's why it is recommended to burp their back while the parents feed their babies by using whether Maid Johnson's feeding tube or Haberman's feeding tube or Pidgeot's feeding tube. So during that time, they need to burp, unless and otherwise there will be high probability of insufflating the stomach. And as a reflex, this insufflated matter will just aspirate out from the stomach and get entered into the lung. So those patients will have high probability of upper respiratory tract infection and aspiration pneumonia. So the other thing, upper airway obstruction. Those patients, since some genetic and epigenetic factors were going on in intrauterine life, so there is high probability of atypical pattern of airway like laryngeal inlet, the vocal cord narrowing, etc. And the other thing, repetitive upper respiratory tract infection. This will put the patient on secretions. There will be a defensive secretion will be there. So during intubation and extubation, the patient will have a secretion and there will be aspiration pneumonia. Risk will be doubled. And the other thing, the timing of the surgery, when to do which surgery. The first one, which should be at first sight, is the lip. The aim is, the first one, sealing the defect and enabling the patient to suckle with no difficulty. So there will be a vacuum inside the oral cavity, so that since the lip seal is closed, the patient can suckle. So this lip surgery will be done 3 months to 6 months, and depending on the extent of the defect, some babies might necessitate the pre-surgical nasoalveolar molding or lip adhesion, just to decrease the intraoperative or the surgical burden. So nasoalveolar molding, and the other thing will be lip adhesion. Lip adhesion, just attaching some parts of the lips, the cleft side, so that in the later time, while when we plan to do the definitive lip surgery, it will be easier to approximate. And next to lip, we are going to do a palate surgery. This palate surgery, like the aim is different and the versatile goal surgery. Like the first one, while we seal the defect, the palatal defect, there will be separation of the nasal cavity from the oral cavity, so that the patient's hypernasality will be resolved, one thing. And the other thing, there will not be any escape of food from the oral cavity to the nasal cavity. The other thing, the defect will be sealed and the speech will be improved. Like whether it is unilateral, bilateral, or complete, incomplete, submucosal, not submucosal cleft, soft palatal cleft, hard palatal cleft, complete cleft, unilateral, bilateral. According to view, this palatal cleft is classified into 4 group 1, group 2, group 3, and group 4. And the group 1 is just this soft palatal cleft, and group 2 will be hard palatal cleft, and group 3 will be complete unilateral cleft palate, and group 4 will be complete bilateral cleft palate. So these surgeries for the lip and palatal surgeries does have their own surgical technique. We are going to discuss it in later videos. And the next thing will be, we will evaluate the patient's speech, because the patient needs this speech therapy. Thus, the palate surgery is done averagely from 10 or 11 months to 12 or 1 year. 12 months or 1 year. So this is because when we do in the early stages the palate surgery, there will be high probability of growth restriction in the pediatric age groups. So in order to avoid that, we will make it as little as possible. So it's just approximately just 11 months to 1 year of age. And even some advocates the approach of incomplete cleft palatal surgery, which means just we will close only the soft palate one, just the muscles, and then so the bone will grow sufficiently. So when we just perceive that it is sufficiently have grown, we will do the bone surgery, or the primary and hard palate and the premaxilla will be sealed. So the aim of this is just in order to avoid any risk which have a probability of hampering the mid-face growth. And the other thing will be, after doing this, whenever there is any velopharyngeal insufficiency. Before going to the VPI or velopharyngeal insufficiency, it is just a condition that any surgical technique might have this insufficiency. So when we do this, the palate surgery, our concern will be the first one, sealing the defect. The other one, compartmentalizing the nasal cavity from the oral cavity. The third one, we need to reconstruct the soft palatal muscle sling so that the soft palate will have its capability or its capacity of vibrating while the patient tries to talk. Like those muscles are levator velar palatini, tensor velar palatini, musculus uvulae, palatoglossus, and palatopharyngeus muscles. This palatopharyngeus muscle is sometimes commonly called as the view muscle. So those muscles should be detached from their pathological attachments over the posterior border of the hard palate. So they should be redirected towards each other and form a horizontal pattern or a horizontal manner so that they can vibrate and aid in the patient's speech. And the other thing, so whenever this happens, the VPI happens, we need to do speech surgery during the 3rd to 6 years of age. And whenever we have also revision rhinoplasty, we have to do it during just at the age group of 6 to 7 years. And whenever we have this columella, this is called columella. So whenever there is a deficiency or shortening of the columella, we need to do columella lengthening procedure. But in the better setups, this columella length non-surgically can be treated in the pre-surgical infantile orthopedics approach by just doing nasoalveolar molding and letting the columellar cartilage to grow and lengthen. So we are just making it advanced and lengthening with no surgery. But in the later life, after doing this lip and palate, we need to do rhinoplasty or columellar lengthening procedure. And the other thing after that, and there is also tip rhinoplasty or rhino. The next thing will be alveolar cleft. Those patients will have alveolar clefts, most commonly at the area of junctions of the where the lateral incisors and the canines erupt. So this site has to be filled with bone so that the upcoming or the erupting canine or lateral incisor will have sufficient bone. For this, we can do this alveolar bone grafting surgery. So the timing will have 3 divisions. The first one, early, intermediate, and late graft surgeries. Early will be 3 to 5 years. The intermediate will be 5 to 7, and the late will be 7 to 11 years of age. We will do the alveolar graft surgery for the alveolar cleft, so that the patient will have a very conducive eruption pattern, and those eruptor tools should be guided by a cleft orthodontics, so that in the later age, after correcting all the dental problems, we can plan for orthognathic surgery. This orthognathic surgery will be planned in order to correct any osseous problem after the patient have finished or his growth in the 17, 18 years of age. We can do this orthognathic surgery after all the orthodontic camouflaging is done. We will do that. So the main aim of this issue is this cleft lip and palate surgeries need a multidisciplinary and timely and a very sticky follow-up, since most of the time it is just it has to be from the prenatal life till the teenage. From prenatal life, starting from most commonly on ultrasound, we can detect this cleft lip, and in more advanced ultrasound, we'll detect cleft palate during or after 12 weeks of intrauterine life or 14 weeks of intrauterine life. So from that time till the 18, 20 years of age, those patients need the primary holder of those patients, oral and maxillofacial surgeon, the plastic surgeon, otolaryngologist, orthodontics, prosthodontics has to be involved for the overall whole well-being of such kind of patients. Gracias.